Good afternoon. I would like to thank Patients Out of Time for inviting me to speak at this conference. It is always an honor to speak for this wonderful organization. My name is Genester Wilson King, and I'm a board certified obstetrician and gynecologist with over 20 years experience providing compassionate and research-driven care to patients. In 2010, I founded Victory Rejuvenation Center, which is a private, holistic, and integrative wellness medicine practice that provides life transforming management modalities to patients. I am also vice president of the Society of Cannabis Clinicians and on the board of directors for Doctors for Cannabis Regulation. I've also co-authored 3 published research articles on the assessment of the impact of cannabis on female and male sexual function. And I've also authored 2 training modules for the new Society of Cannabis Clinicians training curriculum. And finally, I'm an expert on cannabis use in women's health and a master in hormone therapy for women and some men. Thank you. I'll begin. Today, I'm going to talk about cannabis use in women's health. I have no financial conflicts or disclosures to speak of. The objectives today, I'm going to show you how cannabis can help with the symptoms of menopause, and we will also understand what we know about cannabis and its impact on women's sexual health. I have a favorite saying I'm going to share with you. Many women's health conditions have multifactorial components, including mood, pain, poor sleep, and or hormonal dysfunction. The capacity of cannabis to act as an anti-inflammatory agent, a muscle relaxant, a mood enhancer, a sleep remedy, and a pain reliever all at the same time make it ideal for women's health conditions. Let's look at the endocannabinoid system and the hormonal system. The events of the ovarian cycle are controlled by an interplay of hormones secreted by 3 structures. Those are the hypothalamus, the anterior pituitary, and the ovary. Together, they are known as the hypothalamic pituitary ovarian axis. The blue boxes on your screen are the important organs in the HPO. The black boxes indicate the components of the endocannabinoid system that have been identified. The yellow ovals represent the hormones that are released along the hypothalamic pituitary ovarian axis. Now, you'll see here that gonadotropin releasing hormone is secreted from the hypothalamus. It stimulates the release of FSH and LH from the anterior pituitary gland. FSH and LH regulate the growth and development of the follicle and stimulate the ovaries to secrete estrogen and progesterone, as we see here. Now, high levels of endocannabinoids and exogenous cannabinoids can suppress the release of gonadotropin releasing hormone, FSH, LH, estrogen, and progesterone. This is more consistently seen in animal studies than in human studies. In fact, it is an inconsistent finding in human studies, and tolerance may play a role in that inconsistency. The endocannabinoid system regulates almost all levels of female reproduction, starting with oocyte production all the way through the childbirth. Dysregulation of the endocannabinoid system is associated with the development of gynecological disorders. Now, there exists a bidirectional relationship between the endocannabinoid system and gonadal hormones. If changes to the HPO axis, that's the hypothalamic pituitary ovarian axis, occur, this can impact the functioning of the endocannabinoid system. And by the same token, the endocannabinoid system is involved in many functions regulated by gonadal hormones. So this bidirectional interaction between the 2 systems is much more complex than I've stated. There are many more nuances. Here are a few examples. The estradiol, the primary hormone in women, regulates the functioning of Fa, fatty acid amide hydrolase, the principal catabolic enzyme for the endocannabinoid anandamide, and MAGL, monoacylglycerol lipase, which is the catabolic enzyme for 2-AG. Estradiol also regulates and modulates the female response to cannabinoids, mainly through central cannabinoid 1 receptor expression. Also, imaging studies have shown that brain levels of cannabinoid receptors increase in aging females, mirroring the changes in the estradiol levels. As the estradiol levels decrease, the cannabinoid receptors in the brain increase. Now we're going to talk about cannabis and menopause. Menopause is when a woman goes 12 months without a menstrual period. Its causes can be natural, surgical, or due to chemotherapy or other treatments that impact the ovaries and cause it to stop functioning. Menopause is a situation in which the ovaries no longer produce hormones. The average age of menopause in the United States is 51. Symptoms. There are many symptoms of menopause. I'll point out a few. Psychological changes include anxiety, depression and mood changes, irritability. Things that never used to bother you now just get on your nerves very easily. Focus and concentration difficulties. Then there's the infamous vasomotor symptoms that consist of hot flashes and night sweats and sleep disturbances. There's osteoporosis and there's sexual dysfunction. There are also headaches, the onset of chronic disease and inflammation. Discussing just that aspect is a whole lecture unto itself. There's pain. The loss of hormones leads to multiple changes in the body, many of which lead to increased aches and pains. There's low energy, change in motivation, fatigue, weight gain. As estradiol decreases, cortisol increases, and that accounts for the midsection weight gain women often experience in menopause, among other factors. I could go on, but I won't. Since I have a short time, I'll discuss the 4 areas on the slide and discuss how cannabis can help. Now let's look at the psychological changes. They can consist of any of the changes you see on your screen. And often women are placed on conventional medications to address each symptom of menopause. Even before menopause is diagnosed, women are prescribed antidepressants, sedatives, anxiolytics, and other medications. Menopause is a condition of hormone deficiency. It is not a deficiency of Prozac, Xanax, or other medicines. And therefore, hormone therapy is the mainstay of treatment. However, there are some women who are afraid of hormone therapy or in whom therapy is contraindicated. I can assure you, with a knowledgeable hormone specialist, we can allay your fears. But if hormone therapy is contraindicated or truly unwanted, cannabis can be helpful. And I'll show you how. CBD, you see on the left of your screen, or my left, I should say, you're right, probably. CBD is an effective anxiolytic, mood stabilizer, and antipsychotic. But it doesn't work as an agonist as at the CB1 receptor as THC does. Actually, CBD is an agonist at the serotonin 5-HT1A receptor, acts similar to Buspar, facilitating the increase in the body's serotonin levels. CBD also indirectly inhibits Fa, thereby increasing anandamide levels. CBD also exhibits activity in the emotional, processing area, and memory and cognitive areas of the brain. THC, on the other hand, acts like an anandamide and is a partial agonist at the CB1 receptor. It has well-known effects in the brain, including decreasing intrusive memories and the constant fight or flight state by acting on the amygdala. It increases serotonin, thereby lessening depression, frontal cortex area, and it improves mood and memory while decreasing fight or flight mode. That's in the hippocampus. THC is dose response is biphasic. Low doses are sedating while high doses are stimulating. CBD's allosteric binding to the CB1 receptor can reduce THC induced anxiety, should that happen. Let's look at the vasomotor symptoms, the all knowing hot flash. A hot flash is the sudden feeling of warmth in the upper body, which is usually most intense over the face, the neck, and the chest. Night sweats are hot flashes that happen at night, and they may disrupt sleep. Hot flashes and night sweats affect 75 to 85% of women. How often hot flashes occur varies among women. Most women report having hot flashes, experience them daily, and usually it will last 7 to 10 years, with about 10% of women never experiencing a hot flash, and 10% of them have them the rest of their lives. That does not sound like fun. Hot flashes are most commonly caused by changing hormone levels before, during, and after menopause, but it's not clear exactly how hormone changes cause these hot flashes, because I've seen patients that have hot flashes and their estradiol level is normal. So there is something else going on. Most research suggests that hot flashes occur when decreased estrogen levels cause your body's thermostat, which is in the hypothalamus, to become more sensitive to slight changes in body temperature. When the hypothalamus thinks your body's too warm, it starts a chain of events to cool you down. Hot flashes can impact your daily activities and your quality of life. Nighttime hot flashes can wake you from sleep and can cause long-term sleep disruptions. The thermoregulatory center, in association with gonadotropin-releasing hormones, remember that comes from the hypothalamus, is involved in the etiology of hot flashes too. There is a very limited number of studies done on the effects of cannabis or CBD for hot flashes and night sweats. My clinical experience is such that about 35% of my patients have felt relief of their hot flashes using cannabis, maybe 35%. The rest experience no effect. Some have limited effect, and even some report a worsening of the hot flashes when they use cannabis. But what I have noticed clinically, and this is all clinical speculation and observation, I've noticed that the patients who experience severe anxiety with the hormonal changes do better with cannabis and have relief of their hot flashes with cannabis. And usually it's CBD dominant chemovars. Now let's look at sleep disturbances. The risk of insomnia increases into menopause, with as many as 61% of postmenopausal women reporting insomnia symptoms. Menopausal sleep complaints are often accompanied by depression and anxiety. And by the same token, a lack of sleep can cause or contribute to anxiety and depression. This is a vicious cycle. So can cannabis help? Well, endocannabinoids are important in sleep and sleep neurophysiology. Sleep patterns are clearly altered by cannabinoid drugs. We have the National Academy of Science, Engineering, and Medicine report stating that there's moderate evidence that cannabis or cannabinoids are effective for improving short-term sleep outcomes in various individuals. THC exhibits sedating effects, and they're dose-related, and THC decreases the frequency and severity of nightmares. However, chronic use of high doses of THC can decrease REM sleep. Lower doses do not appear to disrupt sleep architecture, so it's very important to stay with the low doses. Again, CBD is alerting at low doses and sedating at high doses. Clinically, CBD's assistance with the sleep disturbances in menopause are inconsistent. THC really seems to be most effective in sleep. Now, let's look at how the endocannabinoid system is involved in bone metabolism. Osteoporosis is a condition where there's loss of bone mass, and this loss of bone mass is increased when women go through the menopause transition. Now, this figure, though it looks complicated, I'm going to explain it to you. It's an illustration from an article entitled Bones and Joints, the Effects of Cannabinoids on the Skeleton. And I did receive permission to share this illustration with you. Now, the picture to the right of the bone, of the long bone, shows that the endocannabinoids, including anandamide, 2-AG, which are found in the bone environment. There are also endocannabinoid receptors, CB1, CB2, TRPV1, and GPR55, located on the osteoblasts and osteoclasts. Now, next, on the other side of the bone, you'll see a dorsal root ganglion depicted, which travels to the periosteum and cortical bone. These structures synthesize endocannabinoids on demand and release these into the synaptic cleft, just as it does with the nerves in the brain and spinal cord. Osteoblasts and osteoclasts contain enzymes for endocannabinoid synthesis. Anandamide preferentially binds to CB2, which is the predominant endocannabinoid receptor found in bone. Now, normally bone formation and bone resorption are in balance. That balance depends on many factors, and following menopause, there's a loss of about 3 to 5% bone mass per year. The bone mass loss occurs primarily in trabecular bone, which is the wrist or the vertebrae, actually distal radius, and cortical bone, the shafts of long bones. These changes lead to symptoms of back pain, loss of height, kyphosis, and this can cause pain, and cannabis can be very helpful in this arena. Now, there is a paper by White et al. That looked at the GPR55 receptor. It affects osteoclast formation in vitro and bone mass in vivo. GPR55 is expressed in human and mouse osteoclasts and osteoblasts. Stimulatory effects on osteoclast function were attenuated in osteoclasts generated by the GPR55 antagonist, CBD. So CBD attenuated bone loss, but this has only been seen in animal studies. It has not been demonstrated in human studies. I report this to you just to show that there's a possibility down the road that we can show that cannabis may be helpful with the prevention of osteoporosis. We're a long way from that right now, but who knows what the future holds. Now, let's talk about sex. Hormones affect sexual arousal through sensory perception, central and peripheral nerve transmission and discharge, peripheral blood flow, and the capacity to develop muscle tension. Now, decreasing estrogen affects the integrity of the female reproductive tract tissues, including decreased vaginal lubrication and atrophic vaginitis, resulting in dyspareunia, meaning pain with intercourse. Decreased blood flow to the reproductive organs results in diminished vasocongestion. I'll tell you why you need that in a minute. There's also progressive ischemia and thinning of the barrier layers of skin and mucous membranes, and loss of subcutaneous fat, and a shrinking introitus that are the changes, the result of hormone deficiency. The most notable effect, however, is the effect on the orgasmic response. Altered nerve function due to estrogen deficiency may delay clitoral reaction time and result in slow or absent orgasmic response. This effect, along with delayed or absent vaginal secretion, diminishes orgasm intensity. Now, that will bring us to our discussion about cannabis and sex. Now that you've heard all of these changes that occur in the menopause transition, let's see how it affects sex and how cannabis can help that. But first, let me summarize cannabis use in menopause. There are many physiologic and psychologic changes that take place in women during menopause. Hormone therapy is the mainstay of treatment. The endocannabinoid system and hypothalamic pituitary ovarian axis, you say that really quickly, are intimately related. Phytocannabinoids can be helpful with many of the symptoms of menopause and maybe even in conjunction with hormone therapy. More studies, many more studies are needed in menopausal and postmenopausal women specifically. We are, we are not the same as women of reproductive age. Cannabis and sex, let's talk about it. The endocannabinoid system is involved in female sexual functioning. In a study by Klein in 2017, the increase in the physiologic and subjective indices of sexual arousal were significantly associated with decreases in anandamide and 2-AG. This was a very small study, though. It was an N of 21. In another study where the N was 211, and this was in 2019, cannabis helped men and women relax and experience heightened sensitivity as in that study. There was also another study done in 2019 that looked at women who used cannabis just prior to sex. The survey consistently showed increased intensity of orgasms and improved satisfaction with orgasms with the use of cannabis prior to sex. Now, if we think about cannabis physiologically, cannabis may help because of its ability to cause vasodilation, which in turn improves the blood flow to the clitoris and the vaginal walls. Remember, I stated earlier that with menopause, you get a loss of vaginal moisture, thinning of the vaginal walls, shrinking of the introitus, and a definite change in the intensity of orgasms. So opening up the blood flow to these areas can really facilitate satisfaction in sex. But clearly more research is needed to elicit the mechanism of action of cannabis and further delineate hormonal deficiency changes and how the hormones and cannabis can work together. There's some other literature findings, and the literature is kind of back and forth. There was a survey in 2004 that found that cannabis inhibited orgasm and painful intercourse. An Australian study found that cannabis could cause sexual dysfunction. That was in 2010. There's also a study in 2017 that actually measured plasma levels of endocannabinoids, 2-AG and anandamide, and a few others before and after masturbation to orgasm. And this study showed that 2-AG is involved in the human sexual response, and 2-AG release played a role in sexual arousal and orgasm. 2-AG levels were actually increased in these situations. Two other studies by colleagues of mine whom I did a study with. 2017, there was a study, a survey that looked at sexual frequency and cannabis use. And they found that the higher cannabis users had significantly higher sexual frequency compared with never users. And in 2018, they looked at the time to pregnancy and found that cannabis had no impact on time to pregnancy. There was a control group as well as a cannabis users group. Now, the exact mechanism by which cannabis works, we don't know, as I've already stated, but cannabis can be incredibly helpful, but not always. Now, I'll tell you about the study that we did. This is a study where we decided to look into the specific information about the types of cannabis chemovars used, the frequency of use, the reason for use, and the route of administration, and also to incorporate a known validated tools to screen for sexual dysfunction in women. It's called the Female Sexual Function Index. This index, it shows you here on this slide, assesses 6 domains: desire, arousal, lubrication, orgasm, satisfaction, and pain. And values that score below 26.55 are classified as indicating female sexual dysfunction or some degree of sexual arousal disorder or orgasmic disorder and hypoactive sexual desire disorder. Now you see some scores on here that are 0. They denote people who were not sexually active. At least you put a 0 if they weren't having sex. Now there were some interesting findings. Women who were older than the age of 50 were likely to have lower total FSFI scores, as they were also more likely to have comorbidities. That's expected, right? You go through menopause, there's more medical issues, etc. Now, when we stratified the results by frequency of use, we categorized it to more than 3 times a week compared to less than 3 times a week. And we found that those who used cannabis more frequently had overall higher FSFI scores and higher subdomain scores. Did that mean they were having better sex before? Or did the cannabis really help? We don't know. The dominant cannabinoid chemovar used most frequently was THC dominant, with a score of 48 to 8.9% for CBD dominant. More comorbidities were associated with higher odds of sexual dysfunction. That makes sense. The most common, if you have medical problems, it's likely to cause some sexual dysfunction. The most common reason for cannabis use was to relax, to relieve stress, and help with sleep. And the more frequent users smoked flower or vaped, the less frequent users used more edibles. And finally, the method of consumption, cannabis chemovar, or primary reason for consumption, did not impact the FSFI scores. And this is just a chart of the age groups. So you see the bulk of our patients were between the age of 30 and 59, 30 and 60. And you also see, I just want to point out one thing, that the younger users smoked more, while the older users used more tinctures or oils and used more topicals. The older menopausal users had more aches and pains for which to use topicals versus the young folks. And smoking decreased as age decreases. Now, this is a finding in this study, and really doesn't, I don't mean for it to be generalized. Now, their study conclusions that the increasing frequency of cannabis use is associated with improved sexual function, increased satisfaction, improved orgasms, and increased sexual desire. And neither the method nor the type of cannabis consumed impacted sexual function. What were the limitations of the study? Our female participants came from a population of cannabis users who made a purchase at a cannabis dispensary during a specific time period, and that may represent a selection bias with a possible skewed population. Though frequency of use was assessed, the actual exact dosage of the products was unknown. Also, we didn't include a non-user group, and that might have altered the findings a little bit. It actually may have made the findings appear more significant. It's also possible that the more frequent female cannabis users happen to have higher FSFI scores before using cannabis, which I mentioned before. Now, there also may have been some residual confounders that were not examined, such as partner issues and things like that, that the FSFI doesn't really cover. There are also, the FSFI is the most commonly used screening tool, but there are other screening tools that if they were used, they could have affected the results as well. And finally, we didn't differentiate between chronic users and new users that may have altered the changes as well. Now let's summarize the cannabis impact on female sexual health. The endocannabinoid system is definitely involved in sexual functioning. Cannabis can positively impact women's sexual health. There's heightened sensitivity to touch. There's increased intensity of orgasms and satisfaction with orgasms. There's increased frequency of sex, and some women actually experience adverse effects. The exact mechanism is unknown, and definitely more research is needed. This plant is so complex, the research can go on and on for decades, but we must overcome these barriers to research so we can really get moving on the research of this powerful plant. I'll conclude with my saying, many women's health conditions have multifactorial components, including mood, pain, poor sleep, and or hormonal dysfunction. The capacity of cannabis to act as an anti-inflammatory agent, a muscle relaxer, a mood enhancer, a sleep remedy, and a pain reliever all at the same time make it ideal for women's health conditions. One final note, I want to talk to you about the Society of Cannabis Clinicians clinical training curriculum. There's 19 of the 23 new modules released. They are on our website. Cannabisclinicians.org is the website. There will be a total of 23 modules, all of which will be released by the end of May. And they can be accessed from anywhere in the world, and you do get a certificate of completion. We invite everyone to join the SCC, as you'll get a 20% discount on all the educational courses, plus free access to quarterly presentations and other presentations that we're doing. So please look at cannabisclinicians.org and please join us. I want to thank you for spending a little time with me. I can be reached at Dr. Wilson King at drwilsonking.com if you have any questions, and my website is victoryrejuvenationcenter.com. Thank you so much, and it's always a pleasure to talk to patients out of time.